मुझे बता दो।
Good evening, everybody. Welcome to this. Everybody to mute themselves. Welcome to this another session of 42nd comprehensive course on echocardiography. And we are very fortunate to have Professor Naveen C. Nanda today to discuss about aortic regurgitations. A little bit, I can say only a tiny bit I can talk about Dr. Nanda. He's a distinguished professor of medicine, Division of Cardiology at University of Alabama at Birmingham, Alabama. He has been the president of International Society of Cardiovascular Ultrasound. I'll say teaching is his profession as well as his passion. He's first of those few Indians who have been instrumental in invention of various techniques of echocardiography. To name one of them is aortic regurgitation, where he was instrumental in telling us how severe the aortic regurgitation is. There's talking of jet with height oblique LVOT height. He has written several books on echocardiography, the latest being the textbook of echocardiography as well as the manual. And he has published more than 1,000 papers in international peer-reviewed journals till date. Moreover, hundreds and thousands of students from all over the world have worked in his lab in Alabama, especially Indians and Asians. I remember an incident when one of our girl students landed up with him at 12 o'clock in the midnight from India, and he was there to pick her up and take her to the hostel by himself along with Mrs. Dr. Kanta Nanda. That is his love and affection toward all of us and the youngster generations. The contribution to development of Indian Academy of Echocardiography is immense. He has been passionate about development of Indian Academy of Echocardiography. He is the international president of Europe Institute of Echocardiography. He has been bestowed with several awards, including the latest one with a Lifetime Achievement Award by American Society of Echocardiography. If I keep on talking about him, I'm going to eat away the complete lectures. With these very few words, I would like to say that we are proud to be associated with him, and we are thankful to you, sir, for your kind blessings and advice all the time we have. It's all yours, sir, to continue the session.
Well, thank you very much, Rakesh. It's really great pleasure and honor for me to come here and give you this lecture. Hope all of you can hear me. You can hear me, okay? Hello?
Yes.
Okay.
Yes, sir.
Okay.
Yes,
Good.
sir. We can
Okay.
hear you.
Okay, it's a great pleasure and honor. And as you know, Rakesh has been the pioneer in teaching of echocardiography in India using this GROP Institute, which is really now affiliated with the International Society of Cardiovascular Ultrasound also. And also, I just heard from a university in Baroda. So really heartiest congratulations to him for doing this. It's very, very rare for cardiologists in India who are very busy in their practice or in their academic settings to do this educational effort, which has done. So that's really great pleasure. My talk is going to be on valvular regurgitation, and let's look at the first slide. Now, most of us actually, when we do an echocardiogram, we are looking at semi-quantitative assessment of valvular regurgitation, and all of that actually, the mitral regurgitation, aortic regurgitation, and tricuspid regurgitation, the semi-quantitative assessment was really developed at the University of Alabama at Birmingham with the help of many fellows from India who came in here. In particular, Dr. H.K. Chopra was instrumental in developing the criteria for semi-quantitative estimation of tricuspid regurgitation. So there's a lot of Indian contribution to some of the things we are still using them routinely in echocardiography as far as valvular regurgitation is concerned. Also now, actually, if you look at this is the 4-chamber view, and if you can see my arrow here on the left side, we can clearly see that there is a flail posterior leaflet of the mitral valve. When you see something like this, there is really no need even for color Doppler. You can see there is a gap between the anterior and posterior leaflet, which is very, very clear. And once you have it, you know that this patient has to have very severe mitral regurgitation. And if you look on the right side here, you can see that what we are looking at is actually very severe regurgitation. We have these turbulent flow signals filling up the whole of the left atrium. So this is not only severe, but torrential mitral regurgitation. Something you have to pay attention whenever you're looking at the semi-quantitation of any valvular regurgitation is to look on the right-hand side. Sometimes it's given on the left-hand side, and you have a color bar here. And that shows you, for example, on the top, it says 61.6 centimeters per second here. And then it's actually, you can see that any flow which is going to move towards the probe is going to be red or very bright yellow in color. Any flow which is going to be away from the transducer is going to be depicted as blue and very bright blue in color. So actually, if you start off here, if you go down here and look at, it starts at 0 here, and then an aqueous limit, and then as you go further, and once you come up to 61.6 on both sides, it should be equal, 61.6 here, 61.6 centimeters per second. Once it exceeds the velocity of 61.6 centimeters per second, then actually it immediately jumps off on the top to very bright red signals, and then it goes down all the way till you get about 123 centimeters per second. So this, and then if the velocity is higher and higher, this would mean the velocity is 123, which means 1 meter and 0.2 or 0.3 centimeters per second. If the velocity exceeds that, which happens a lot with, for example, mitral regurgitation, any aortic regurgitation or mitral regurgitation, it keeps on moving. And so therefore, what you get here is actually a combination of blue and red or yellow signals here. Not only that, many times it has a greenish appearance because the manufacturers, whenever there is a lot of this aliasing, which we call aliasing, when the velocity keeps on increasing, the velocity is very high, you also get green thrown in. So it becomes very easy to identify regurgitant lesion here because it has high velocity and it will have actually a mosaic pattern of colors, which will be red, blue, green, everything mixed together. So really it depends on this Nyquist limit here. And I'll go more on this Nyquist limit later on because this is very, very important where you keep this Nyquist limit when you actually try to assess severity of valvular regurgitation. So here again to show you, that was a 4-chamber view, and this is a long axis view, and you have the left atrium here when I'm circling around. And again, you can see this is actually a mixture of green, red, and blue actually here. And of course, it's mitral regurgitation because in systole, no fluid should actually back into the left atrium from the left ventricle if the mitral valve is competent. If the mitral valve is incompetent, flow signal will go in here. And as you can see, again, it fills up the whole of the left atrium. So this is severe mitral regurgitation. The reason I was telling about the Nyquist limit, now on this side, it is actually on the left side. Some equipment have it placed on the left side as a rectangular bar. Some have it on the right side here. So here is a patient where the Nyquist limit is kept actually low, a little bit low at 48 centimeters per second. And the other important thing to look for is color gain, which is always on the opposite side. And you'll see a sort of a number for color gain. And it's just a number. So the higher number means the color gain is high. The lower number means the color gain is lower. So what has happened here is we are looking at a Nyquist limit kept at 48 centimeters per second. Color gain is around 31. And here you can see this, down here you can see some regurgitation signal here. Note the size of this regurgitation here in terms of in comparison with the left atrium. And actually, if I go further here, now the Nyquist limit has gone up to 80 centimeters per second from 41 centimeters per second. So see what has happened. Same mitral regurgitation, which appeared to be a somewhat moderate in degree. Now, actually, you can see that it's going to be very minimal in degree now, very minimal mitral regurgitation. So what I want to show you is that the Nyquist, depending on the Nyquist limit, you can change the size of regurgitation. So therefore, it's very important to control the regurgitation here, to control the Nyquist limit. And in the beginning, we used to keep it at about 50 centimeters per second. But now what has happened is that since machines have advanced a lot. So you can keep it up to 60 or maximum up to 69 centimeters per second. You can keep the nicotinamide around that time, something like, in other words, you can keep it between 50, or rather, I would say 60 to around 60 or 69 centimeters per second. And that's where the nicotinamide should be kept. So very important to make sure that when you are looking at mitral regurgitation, the nicotinamide is standardized around 60, 69. You can't keep it as one number, because what happens is the incremental value here is stepwise, so it comes in steps. So there's no one number, so it's a range. So you keep it around about 60, you can say between 50 and 69 centimeters per second, more like 60, 61, or up to 69 centimeters per second is good enough. So you keep the nicotinamide at that point, and then you look at regurgitation. The other important thing is also color gain. You should really adjust optimize the color gain also. Now let me go further here, just to show you. Here, for example, the color gain, which was here actually 31, it's an arbitrary number. So we increase the color gain to 46 here. It couldn't be called percentage. Most of the time it's just 46. So it's 46 here. Nicotinamide is still almost okay, 50 centimeters per second. And you can see the regurgitation, the area of regurgitation now here. So now what I will do would be change the color gain only, keep the nicotinamide same, about 50. As I mentioned, you can keep it up to 60, 69. So here you can, now the color gain, I will only change the color gain, keep the nicotinamide same, no change in nicotinamide. So nicotinamide is still 50 centimeters per second. And the color gain now has been decreased to 27%. What has happened? Regurgitation has disappeared completely. So how do you adjust the color gain? What you do is you look at regurgitation and then increase your color gain by tweaking the knob to the right, increase it till you get signals which actually go beyond the left atrium, which actually go beyond the walls of the heart, which go beyond the left atrium. So there's very, very high color gain. So then you slowly bring it down till that the color gain going beyond the walls of the heart just disappear. If you can make it very low, the regurgitation will disappear. So increase the color gain till you see flow signals going beyond the walls of the heart, then decrease it till whatever is going beyond the heart disappears. So it's confined only to the left atrium, and you keep the color gain at that point. So that is how you adjust the color gain. What is really the NICOS limit? NICOS limit, as I mentioned to you, also the aliasing, when the velocity exceeds the certain limit, for example, if it exceeds 50 centimeters per second, is going to show the other color, even though the flow is going towards the transducer, which should be red, it will show also blue also, and if it goes again and again, if the halo is high and again, it keeps moving. So therefore, that shows the aliasing. But also when you increase the NICOS limit, you are also changing the color filter. So you're making the regurgitation signals, the area of regurgitation, smaller. So that is the other property of NICOS limit. It makes the signal smaller as you increase the NICOS limit. So therefore, it has to be controlled. So whenever you're looking at regurgitation, any regurgitation, mitral, tricuspid, aortic, pulmonic, keep the NICOS limit between 50 and 61, or maybe maximum 69, but usually 61 centimeters, 50 to 61 centimeters per second. Adjust the color gain, increase it till you get noise going beyond the walls of the heart, very, very bright noise, a lot of noisy signal. Then bring the color gain down till that the regurgitation jet is within the left atrium, not going beyond the walls of the heart. That's how you adjust it. This is very, very important to keep. It's not emphasized very much in the guidelines till recently only. They were emphasized it, not emphasized before. So this should be done. Otherwise, you're making a big mistake about the severity of regurgitation. There is also a joke here. Sometimes I've mentioned that if the surgeon has repaired the mitral valve and he has done a great job, but you hate the surgeon because he has been rude to you, you can actually keep on increasing the NICOS limit and decreasing the color gain. You can keep on decreasing the color gain and decreasing the NICOS limit and increasing the color gain. And if that happens, the regurgitation would appear to be very severe, when in fact it's not severe. On the other hand, if you're a good surgeon, you like the surgeon, but his results are not very good, but you want when the results are good, you can increase the NICOS limit, decrease the color gain, and if you do that, then you'll see that his regurgitation will appear pretty less. This is a joke here, but just to give you an example that this is very important. So here actually one other aspect here, now here again is a 4-chamber view. And if you look at regurgitation here, these turbulent flow signals are there. But again, remember, these turbulent flow signals are a little bit eccentric, so they actually hit the wall of the heart here, and also, for example, here they're hitting the lateral wall of the left atrium. If that happens, what happens suddenly? The velocity decreases, because if you take a hose with the water and hit against the wall, the velocity is going to decrease because it is hitting an obstruction. So once it hits this we call the Coanda effect. So once it hits the wall, the velocity will decrease. So what happens now is the velocity has decreased here at the bottom. So even this is now, then the jet is swirling around in the left atrium, swirling around. So even though this looks like still it's severe regurgitation, occupying around 40% of the left atrium, actually it's torrential, because it has lost its velocity here. It has lost its speed here, the velocity here. So therefore, these signals become laminar. So even though there is some admixture of pulmonary venous flow here, if you see that in real time, and this is moving around like this in the same phase in the cardiac cycle, then these red laminar signals should also be considered as part of regurgitation. If I do that, then I know that this regurgitation is occupying the whole of the left atrium. So this is actually torrential mitral regurgitation. That's very important. Happens with eccentric jet. Here is another example. You look at this jet here, of course, and you can see the jet is very thin. If I look at only the turbulent flow, I'm going to say, well, this is very mild mitral regurgitation. It's occupying less than 20% of the left atrium. I forgot to mention that to you, that whenever the jet occupies less than 20% of the left atrium, it's called mild. If it occupies between 20 and 40%, it's moderate. And anytime the jet occupies more than 40% of the left atrium, it's really severe mitral regurgitation. And then this, you don't really have to measure the jet. You can look at it by inspection, and you can easily tell whether the mitral regurgitation is mild, moderate, or severe. So here it looks mild because it's less than 20% of the left atrium. But then you remember what happens. The jet is striking the back wall of the left atrium all along here. It has lost its speed. So suddenly the jet has become laminar here, blue signals. And as the jet is going to swirl around in the left atrium, it's going to be red in color because it is going towards the probe, should be red here, red or yellow, red or bright yellow, red here. So therefore, this jet is severe because now you take not only this turbulent flow signal, but add to this all laminar signals, and this is actually torrential, very severe mitral regurgitation. It's very, very important because people always, when there is an eccentric jet, they make a mistake. Some people have said, well, if there's eccentric jet is mild, just add 1 grade. But that may not be very good because here actually adding 1 grade doesn't help. If you look at the flow signals which are moving with the regurgitation jet, turbulent flow signals which are moving with the turbulent flow signals, you know that this is torrential mitral regurgitation. So that's very important. Here is another example in the parasternal long axis view. So here you, of course, see this large flow acceleration. I'll talk to you about that about a minute later. And here is again eccentric jet, looks very mild. But here is again red flow signals going with the jet. In real time, you'll see them moving together, swirling in the left atrium. So again, this occupies now more than 40% left atrium. So that becomes actually a severe mitral regurgitation. That's very important. So just to give you an example about the Nyquist limit, really speaking, the Nyquist limit is given as a rectangle by the manufacturers. Really, it is a circle. That is easier for you to understand. It's a circle actually here. So what happens, but because the circle occupies larger space, so they've converted that into a rectangle. So what happens is, as for example, as actually the regurgitation, let's say, increases, as the velocity increases from dark red, which is very close to 0 here, baseline 0, as increase becomes bright red, very, very bright red, almost yellow. And then and here it is 72 centimeters per second. So once it becomes 73 centimeters per second, it doesn't become dark yellow. It's a circle. So it becomes a very bright yellow, a very bright blue. And then as it increases further to 80, 90, etc., up to 140, it'll become actually dark blue. And then 150, it'll again become dark red, and this way goes on as a circle. So rather than my telling you this goes from 72 to 73 on the top, easier to understand if you look at this as a circle. And that's how the Nyquist limit should really be shown, but the manufacturers show it only as a rectangular, so that you understand. That's why I'm showing this to you. So that's very important. And here now, let's talk about the flow acceleration. So whenever you see actual regurgitation, as the flow converges towards a hole in the mitral valve or the defect in the mitral valve, it will actually show up here on the ventricular side as what we call as a flow acceleration, because the flow will accelerate before it goes in through the hole into the left atrium. So that flow acceleration is there. And here is what to show you again here. So this is a regurgitation. It's much more severe than what it looks like. As you can see, there's also red flow signals. So this is swirling around, severe mitral regurgitation. So if you look on the top here, you have this flow acceleration shown by this arrow, very prominent. And then this is a jet passing through the hole. So this is actually many times, I don't know why they make it complicated. They should call it a hole or defect in the mitral valve, but they want to call it a vena contracta. So let's think of vena contracta as nothing else but a hole or defect in the mitral valve. So here is a vena contracta. And the larger the hole, the larger with the diameter. Here, I'll show you anything more than with a regular Nyquist limit, a normal Nyquist, this is up till about 61 centimeters per second. If this is 7 centimeters or more at the level of the valve. Now, sometimes because the valve is very bright, like you can see here, you may not actually measure it exactly at the valve, but go just 0.1 millimeter below the valve, just outside the valve, just below the valve here. You can measure it here also, or if you can get it through within the valve, you can measure it within the valve. If that is more than 7 millimeters, that goes for severe mitral regurgitation also. So just to give you an idea about measurement of the hole of the vena contracta. So this is the flow acceleration. Think of a sink or a tub, and as the water flows through the tub here, and this also was published the very first time in our book on color Doppler echocardiography, this picture to show the flow acceleration. As you can see, the flow will accelerate here as it goes in the hole. So this is what we call the flow acceleration here, or PISA. Some people call it PISA. Again, it's same thing as flow acceleration. And then here is the vena contracta, which would be the size of the hole here. So whenever you have any mitral regurgitation jet, you can measure the size of the hole, and then you can also measure this flow acceleration. There is some reason sometimes to measure the flow acceleration, because what happens if you actually can go for the flow acceleration and then reduce your Nyquist limit here to something like 40 centimeters or even 30 or 20 centimeters per second, reduce the Nyquist limit here, move the baseline down, and then look at the aliasing velocity here. So for example, it is going down here, and you measure the velocity at which it aliases here, this velocity of flow acceleration or flow convergence here, or PISA radius, you can call it here. You can measure the PISA radius here. And then this is a regurgitation jet. You can calculate the regurgitant flow, not only look at semi-quantitative mitral regurgitation, but now quantitative mitral regurgitation by going with this is actually called hemispherical. So you have it as 2 pi r squared, the area, times the velocity of aliasing, and that will be the regurgitant flow. You can calculate how much flow is going from the ventricle into the left atrium. And then you can calculate the effective regurgitant orifice area, which is same as vena contracta, except now you are going to get the area, not just one length of the vena contracta. And that you can get by looking at this regurgitant flow and divided by the peak velocity across the mitral regurgitation jet. So this looks like it will be a very good quantitative method, but it's not. The reason is you are assuming that this flow acceleration is hemispherical. And I've shown it as hemispherical, but in most instances, in 95% of patients, the flow convergence is not hemispherical. It can be anything except hemispherical, irregular actually, many times. So then in that case, actually, so this method is not really a perfect method, measure the regurgitant flow. And for that, we should really go for 3-dimensional echocardiography if you really want to be very quantitative. But there have been many studies in the literature showing, looking at this flow convergence, looking at the effective regurgitant orifice area using the flow convergence method, and looking at the regurgitant flow volume. There are many correlations with prognosis, et cetera. So it is still a useful method, but really not an accurate method at all. So that's something to remember here. One other thing to remember, always you should do a color M mode echo whenever there is mitral regurgitation, because all the time we are assuming that mitral regurgitation is occurring throughout systole. When the hole is there, it's going to occur throughout the systole actually. But you have patients with something like mitral valve prolapse, which you can miss on that 2D echocardiography. And though if there is mitral valve prolapse, then many times, as you know, you have a click and a murmur, mid-systolic click and a murmur. The mitral regurgitation may not be pan-systolic. This is M mode echo, color M mode. This is a mitral valve. It's not going to be pan-systolic, like in this case, it's going to be mid to late systolic. So if the regurgitation is mid to late systolic, you have to take that into account. So in that case, mitral regurgitation, even though it may look severe, may not really be very severe at all, because it is not throughout systole. It may be half of what we think mitral regurgitation severity might be. So that is also very important to do actually a color M mode, or sometimes you can do if you do actually continuous wave Doppler, you will see that the continuous wave Doppler is not pansystolic, but it's only mid-to-late systolic. But color Doppler M mode, as shown here, is very, very important here. So here is something which we published, and this we compiled the guidelines plus other things we have taken all together, and we published it. And actually, it's published in the cardiology update book by I think Dr. Goswami was the editor of that. He's the editor of that book, Dr. Goswami, Keval Goswami. And in that book, we actually published about everything about regurgitation, valvular regurgitation, as well as valvular stenosis. And I really want all of you to really look at that chapter in the book, which is by us actually. Look at that chapter and you'll see all this there. And not only will give you a very good synopsis of valvular regurgitation by echocardiography, how to assess it, but also valvular stenosis by echocardiography. So look at that chapter in Dr. Goswami's book, Cardiology Update, I think 2019, was it 2018 or 2019? That I think published in 2019. So look at that book. So here, for example, how do you look at mitral severity regurgitation? Here is mild, moderate, severe. First of all, you look at mitral valve morphology. As I mentioned, if there is systolic non-capitation mitral valve, regurgitation is always severe. Of course, it depends a lot on LV and LS size. In mild, it will be mostly normal. In moderate, it will be mild dilatation. And severe, it will be mostly dilated. But of course, you don't depend on these, but these are also very helpful ancillary finding for regurgitation. We look at mitral inflow. If it's severe, the E wave might be more than 1.5 meter per second. Don't depend on one criteria. You look at everything. The most important practical one is look at the mitral regurgitation area, like I mentioned earlier. You can look at the mitral valve divided by the aortic valve velocity time integral. And if it's more than 1.4, goes for severe mitral regurgitation. And here I mentioned about the maximum mitral. This is the maximum. Now remember this. The maximum mitral regurgitation jet area using multiple planes, not one plane, multiple planes, divided by the left atrial area, the same frame. And is the most commonly used criterion in clinical practice. This one, if it's less than 20%, is mild mitral regurg. Is more 20 to 40% in between them will be like moderate mitral regurgitation. And anytime it occupies more than 40% left atrium with severe mitral regurgitation. There are other jets here. For example, you can look at the intensity of the jet by color continuous wave Doppler. It's very dense and triangular, it's severe. Less dense, then it's less severe. I mentioned about the vena contracta width. If it is 7 millimeters or more, 7 actually centimeters or more, there is severe mitral regurgitation. And you can look at the PISA estimated EROA, and then you can look at the PISA estimated mitral regurgitation volume. And the best way to look at it is mitral regurgitation vena contracta. And if it is less than 0.2, it's mild mitral regurgitation. Moderate is 0.2 to 0.4. Severe is more than 0.4. I'm not going to go into more 3D echo because most of you may not be doing 3D echocardiography, but just to get an idea that if you want to be really quantitative, go for 3D echocardiography, color Doppler of mitral regurgitation. We'll go now to the aortic regurgitation. Unlike mitral regurgitation, where we looked at the area of the jet, and we found, again, all this has come from our laboratory, as I mentioned earlier, mitral regurg, aortic regurg, tricuspid regurgitation. Also, pulmonic regurgitation to some extent came from our lab also. But you don't look at the area of regurgitation. Here you can look at the vena contracta, or the size of the hole. Vena contracta simply means hole or defect in the valve. So you look at the defect in the valve here and relate it to the left ventricular outflow tract in the same place, and then look at the ratio. And again, you can do that by inspection. You really don't have to go into to really measure everything. It'll take time. You just look at it and you can get an idea. For example, here, if in the long axis view or 5-chamber view, if the jet width over the left ventricular outflow tract width is less than 25%, that is mild aortic regurgitation. If it is between, I should say, 25 to 46%, it's moderate aortic regurgitation. If it is between 47% and 64%, then it's moderately severe aortic regurgitation. And if this jet width over alveolar width is more than 65% or 65% more, then this is this severe aortic regurgitation. And this is the Hunt's angiographic criteria. This is what we did. We took all these patients, just like a mitral valve, we used Nagel's criteria with angio. We did angio studies in the 1980s. Here also in 1980s with the aortic severity ratio here. And so this is the thing you do. Very easy, less than 25% mild, 25 to, you can call it 50, moderate, up to 60, up to 2/3, moderately severe. Anything more than 60, more than 2/3 of the outflow tract, if the jet occupies anything more than 2/3 of the outflow tract, is severe aortic regurgitation. We go next year. So here, for example, now don't look at the jet width here. This is wrong. You look at the jet width exactly where it comes out of the aortic valve, at the level of the aortic valve or immediately below the aortic valve, because you are looking at the hole. Once the jet comes out of the hole, it's going to widen because of the blood pressure, but in diastolic blood pressure. Because here you look at this jet, which is very, very tiny, and definitely by inspection, less than 25% of the outflow tract at the same point. So at the origin of the jet, you should look for origin of the jet. It comes out to be 21% here. So this is mild aortic regurgitation. Here is very old, just for historical effect, the very early studies which we did, published during the very first paper we published. Again, look at the jet, origin of the jet here, not the late further on. Origin of the jet is less than 25%. So this is mild aortic regurgitation. 5-chamber view, mild aortic regurgitation, very thin, origin is very thin. Don't look here, look at the origin. That's very important. So aortic regurgitation is a little bit different way to estimate quantitative. Here, for example, oh my God, look at this. This aortic regurgitation jet is occupying more than 90%, the origin, 90% of the outflow tract. So this is very severe potential aortic regurgitation. 5-chamber view also, this is aorta here, 5-chamber view, again occupies more than almost 100% of the outflow tract width. So very severe potential aortic regurgitation. Another one, very severe regurgitation, shows the turbulent flow very well with red, blue, green, yellow, all types of sorts of signals are mixed in. So this is severe aortic regurgitation. Aortic regurgitation can also be eccentric. And then again, you look at here you don't have to worry because you are looking at the origin of the jet. So the origin of the jet here would be like something like moderate here. And again, the jet actually is hitting the septum. It's going to be mostly red in color, but then as it hits the septum, the velocity decreases. And this is also aortic regurgitation, but now it is blue in color. So remember that also, when it hits any wall, the velocity will decrease, become laminar velocity, laminar flow velocity without any aliasing, without any duplicate color. Sometimes you have a problem and you want to check if the aortic regurgitation is really severe or not. For example, if there's vegetation near the aortic, you may not see the jet very well because the vegetation is going to interfere with your jet width. In that case, you look and do the suprasternal view. And in the suprasternal view, you place a transducer at what we call the isthmus. So here we have the ascending aorta. Then we have the transverse aortic arch. And the ascending aorta junction of to standardize it, you go for the junction of the arch of the aorta with the descending aorta. So you place your pulse Doppler sample, not continuous wave Doppler, but pulse Doppler sample volume right in this area here and look for any backflow. And normally you would see the backflow is not so prominent and it's not pan-diastolic. And this is all noise. Remember, don't call this pan-diastolic. So you always have a little noise in pulse Doppler. This is also noise. This is a real tracing. This is noise, very low velocity noise on both sides of the baseline. That's noise. Here is the real signal, and this signal is very small and not pan-diastolic. It doesn't go throughout the diastole here, only early diastolic. So this patient and the pulse Doppler sample volume is kept at the isthmus here, at the junction of the transverse arch with the proximal descending aorta. So when this signal becomes prominent and pan-diastolic, they'll go for severe aortic regurgitation. So if you're a patient you suspect has severe aortic regurgitation, but you cannot really measure it in the parasternal long axis view or apical 5-chamber view, you can go into the suprasternal view and make sure you keep the sample volume properly here. Nyquist should be same as standardized. And then if this is pan-diastolic, you can call it severe aortic regurg, not pan-diastolic. It's actually, it's not, it would be less than severe regurgitation, aortic regurgitation. Of course, you'll be careful here because once in a while, if there is a PDA or if there's a shunt in this area, then this can be pan-diastolic. So renal shunt sometimes can produce pan-diastolic. So except for those 2 or 3 exceptions, this also works very well. Let's say there is a bandage in the suprasternal area. Then you can go for abdominal aorta, proximal abdominal aorta. And again, there you look at the diastolic backflow. And if it's prominent and tends to be pandiastolic, they'll go for severe aortic regurgitation. So that is very important. So here actually very important, measure the aortic jet width at aortic valve level, practically within the valve or just below the valve, ventricular aspect of the valve we can call it. Use parasternal long axis view, but if not, then you can use five chamber view, because LVOT has maximum width in the parasternal long axis view. And then you can look at prominent pandiastolic backflow in the proximal descending aorta or abdominal aorta, goes for severe aortic regurgitation. So some of the things to remember. So here again is from what the table that we made after we were many fellows working on this to look at all the literature, all the guidelines. We put the table together. Very important for you to look at that chapter. And I'm sure Dr. Rakesh Gupta can find that chapter, give you reprints of that. This is aortic regurgitation, maximum jet width, inner LV output width. Same thing with less than 25, just to round it up, 26 to 50, moderate, more than 50%, moderately severe, more than, 65%, 2/3 of the LV outflow tract would be severe aortic regurgitation. So these are some of the things. Again, ventricle, also you can look at the, some people have looked at the VC area, calculated by 3 TTE, and if it's more than 0.4, then more than 0.6, it becomes severe aortic regurgitation. More than 0.4 centimeter square is severe for mitral regurgitation. More than 0.6, a little bit more than 0.6 square centimeter, it becomes for severe aortic regurgitation. So that's one thing you need to look at. I'll briefly go over the tricuspid regurgitation. Again, what criteria we use? Very similar criteria that we use for mitral regurgitation. Look at the area of the jet and relate it to the right atrium. This work comes from Dr. Chopra's work, actually. He also looked at the annulus. The larger the annulus, the more severe would be the tricuspid regurgitation. But here, when we call as severe regurgitation, rather than going for 40%, we found that 34% or 35% was good enough. So tricuspid regurgitation, if the jet occupies more than 35% of the right atrium, that becomes severe tricuspid regurgitation. And then, of course, if the less than 20, it would be mild tricuspid regurgitation. Between 20 and 34% would be moderate tricuspid regurgitation. So this is one way to look at the tricuspid regurgitation jet. So here again, just like as mitral regurgitation, if you see systolic non-coaptation of the tricuspid valve, the valves are not coming together properly. There's a gap between the leaflets of the tricuspid valve. Then, of course, you don't need even color Doppler. It's severe tricuspid regurgitation. Look at the RV and RA size. They'll be, and if it's severe, maybe they'll be dilated. But these are all ancillary findings. You can look at IVC diameter, and if it is at more than 2.5 centimeter, then again comes out to be severe tricuspid regurgitation. As I mentioned to you, look at the maximum tricuspid valve annulus diameter in diastole. And if it's more than 38, comes out to be severe tricuspid regurgitation. Now the people, to round it up, call it 40. If they're more than 40 millimeters, they said that go for severe tricuspid regurgitation. And then, of course, you look at if there is systolic flow reversal in a vertical hepatic vein. I'll show an example of that. They'll also go for severe tricuspid regurgitation. We found that once in a while, moderately severe tricuspid regurgitation may also show it. But I think in general, if you see systolic backflow, it'll go for severe tricuspid regurgitation. Of course, here it is. Maximum tricuspid regurgitation jet area maximum divided by the right atrial area in the same frame by TTE. Useful and most commonly used parameter in clinical practice. If it's less than 20%, is mild tricuspid regurgitation. 20 to 34% is moderate. Anything more than 35%, which means more than 34, which means 35% or more, be severe tricuspid regurgitation. So, and also same way we can go on to the vena contracta. You can read that chapter for more details also. Again, the Nyquist limit, just to show you, very important, something people are not looking at very well. Here is the Nyquist limit is 30 centimeters per second. And this is the, actually it's mitral regurgitation only. I didn't put it in the wrongly in the tricuspid regurgitation. And here you can actually see the jet size here. Now, once it goes higher up, the jet actually will become smaller. And here it goes to 80 centimeters per second. very little tricuspid regurgitation. So if the Nyquist limit, the way I mentioned to you, between 50 and 60, between 50 and 69, preferably about 60, 61 centimeters per second in that range. And then here again, so here you can actually, the jet can become erroneously very small when you increase the Nyquist limit. Let's look at the gain, color gain here. Here we are now going to tricuspid regurgitation, just to give an example that it can have, you need to do the same for not only mitral regurg, but also tricuspid regurgitation. Here the gain is 30%, and you can see the area of the jet is not that much. You go to 70%, and the area is large, which is really correct. This is correct. Now you don't see any jet signals going outside the walls of the atrium here. And then when you go to 100%, very high gain, you can see the jet is actually going beyond, involving the wall of the left atrium here, going even outside the wall of the right atrium, and here also going into the, almost into the left atrium. So this is very high gain. So from here, decrease it slowly till this extra noise around the right atrium disappears, and you take that as your, use that, grade the severity of mitral or tricuspid regurgitation. Here, just to show you tricuspid with very high color gain, what has happened is the jet is going everywhere. Jet is going not only in the right atrium, but also into the left atrium, outside the wall. Here is the wall of the right atrium, going outside the wall. And here, where we do the optimal color gain, now you can see the tricuspid regurgitation was severe here. There's also this red flow signals, swirling of the jet, very severe tricuspid regurgitation. And then here again, when you decrease the gain a lot here, very low color gain, the tricuspid regurgitation jet can disappear. So again, to very emphasize the importance of Nyquist limit and color gain, we look at jet area all the time when we in clinical practice, but don't pay, you have to, but we don't many times pay attention to Nyquist limit and color gain. You must pay attention to Nyquist limit and color gain. Here again, to show you the swirling of flow of the tricuspid regurgitation jet appears severe. It is severe here, more than, I think it's probably about 20, 30%, but it is swirling around. So take into account the red flow signals also, and they'll go for severe tricuspid regurgitation. Also look at the flow acceleration, it's very, very severe here. And this is just to show you, this is systole here. Here you can see this is systole, looking at the ECG. And in systole, we have color flow signals moving into the hepatic vein. You'll be able to see that on the pulse Doppler also. Use not the IVC that much as one of the vertical hepatic veins, which is very commonly seen, the junction of the IVC, near the junction of the IVC with the right atrium. And if you see these red flow signals, that again goes for, in the vertical hepatic vein, goes for severe tricuspid regurgitation. I don't know whether I can play this eccentric tricuspid regurgitation. Let me see if I can try play that. I don't think it, let me go back. Let's see, it won't play, otherwise I would have shown that to you. No, it's not going to play, so let's forget about that. Let me see this one, there's this one here, okay. So this is just to show you. Now here is actually, again, a patient who has tricuspidal prolapse, not very easily seen on the 4-chamber view here, but when we do a color mode echo, you can see the jet here, tricuspid regurgitation jet is only mid to late systolic, it's not pan-systolic. And when you do a continuous wave Doppler also, you can see it looks like a half continuous wave Doppler. It's not beginning at the systole here, it's only at the point, it's only actually mid to late systolic. So both are useful, and but I think color M mode is even more useful than continuous wave Doppler to make sure. So this jet, although it appears to be quite severe here, fairly severe, is really only mild to moderate because the jet is not occurring throughout systole, is occurring half. So this is also very important to look at, to do a color M mode and continuous wave Doppler. This is just to, maybe this will play. Okay, it's playing. So here is a tricuspid regurgitation. I'll play it again. This tricuspid, which looks eccentric, but then if you, in that case, whenever there's eccentric jet, look for laminar flow signal going with the jet. And if I play it again and again, you see that they're going together with the regurgitation jet. So it's the same. So they are continuous with this regurgitant flow, turbulent flow. So even though it is laminar, this actually patient has very severe tricuspid regurgitation. Although if you look at it only with the turbulent flow signal, you'll call it mild to moderate, but really it is severe. So that's another important thing about eccentric jet. Now, this is not given in the guidelines. Guidelines say eccentric regurgitation is more severe than what it looks. But actually, if you look at this continuous flow signal moving, laminar flow signal moving with the eccentric jet, then again, that comes out to be severe tricuspid regurgitation. And if you see the tricuspid regurgitation going into the coronary sinus, that also goes for severe tricuspid regurgitation. Just to show you color mode aliasing, here actually you can see the flow is laminar. Now here it becomes red because it has exited from laminar here on the left side. It has gone into bright red. So therefore it becomes very bright red. And then when the jet velocity exceeds even further, it becomes blue. So here is the jet with the laminar velocity, low velocity, higher velocity. Now here, not low velocity. It has gone from here up there, again come back here. So this is even higher velocity jet here in this area here, just to give you an idea about the Nyquist limit also. And one important thing about tricuspid regurgitation, because the right side pressures are low, so you don't see turbulent flow many times. For example, here is a wide open tricuspid regurgitation with a big hole in the valve here, big defect in the valve. And because the pressures, the gradient would be very less here, so the flow will still be laminar. So remember that on the right side especially, when you have laminar flow signals in the systole, don't think of turbulent always as being regurgitation. Even laminar flow signals can be actually regurgitation jet. So here is because of the low pressure volume on the right side. So here you have tricuspid regurgitation jet, which is completely laminar, blue flow. There's no green or red or anything in that at all. And yet this is severe tricuspid regurgitation. So remember this also. This is now pulmonic regurgitation. Generally, we use the same criteria because we don't have any way to look at the severity of pulmonic regurgitation by cardiac catheterization laboratory, so we couldn't do that. So what we generally do is just use the same criteria, look at the pulmonic regurgitation jet exactly at the point of exit, and look at the RV outflow tract at the same point. With less than 25% is mild pulmonic regurgitation. In 26 and 64%, you can think in terms of 25 to 50%. It'll be moderate regurgitation. And of course, if it occupies more than 2/3 of the RV outflow tract, is severe pulmonic regurgitation. One other thing, if you see the pulmonic regurgitation jet extending, now it'll be red in color as it goes out of the pulmonic valve, but then it's going to turn around. The RV outflow tract turn around, become blue. And this blue will be part of pulmonic regurgitation. If you see that jet within 1 centimeter of tricuspid valve, that is also severe pulmonic regurgitation. So when we go for pulmonic regurgitation, we're really going to look at the over the right ventricular outflow tract. Use the same criteria as for aortic regurgitation in quantifying it as mild, moderate, or severe. And of course, if you see pulmonic regurgitation jet extending within 1 centimeter of the tricuspid valve, or sometimes actually it can go into the right atrium also because of the incomplete coaptation of the tricuspid valve, that also goes for severe pulmonic regurgitation. And if you go by the 3D echo, anytime the vena contracta area by three-dimensional transthoracic echocardiography is more than 1.1 centimeter, so more than 1 centimeter square, it will be severe pulmonic regurgitation. But tricuspid regurgitation also is around 0.8 or 0.9. So if it exceeds 1 centimeter square, it will be very severe tricuspid regurgitation by 3D echocardiography. I'm not going to go very much into 3D echocardiography, but just give you an idea how one actually can semi-quantitate regurgitation in clinical practice, and that's all you need most of the time. When the regurgitation becomes very severe by color Doppler, and then you think now maybe the patient's symptomatic, or maybe at this point in time, something should be done to the valve, then you go for quantitation of regurgitation. Otherwise, there is no need to go for quantitation of any regurgitation using sophisticated techniques like 3D echocardiography. Thank you very much for your kind attention. I hope you could hear everything I said. Thank you so much.